IOL cutter and forceps. One bonus feature at the end. Stop cutting, start slicing. This is the new method by which one has to explant IOLs. Opacified IOLs are even harder to cut. Here the surgeon has made 1, 2, 3, 4 slivers. Here the surgeon has made 3 slivers. Excellent result of 6/6 the next day. Here it's a 32 diopter lens, very thick, very shallow AC. The surgeon decided to break the haptic-optic junction and then cut the optic into 2 parts. The older methods of removal are extending the wound, creating a lot of astigmatism. The twist and out technique requires a lot of skill and cannot be done if there is a V loss or a PC dent, or you can cut with bulky scissors which stretches and pulls on the cornea and also requires a wound extension, and since the scissors open and close, it can also damage the endothelium, can give rise to striate keratitis and even Descemet's detachment. The tip looks like this. You have to prime the phaco with your normal tip first and then screw on the IOL cutting tip. These are the forceps to hold the IOL, and that's the tip. You must try in vitro first. It is smartly using the ultrasonic power of your phaco machine to slice the IOL. Temperatures at both the tips were tested. They're exactly the same. Vacuum 0, aspiration 0, power 30. Irrigation should be on. No torsional, only longitudinal, and no linear. Keep a fixed power. Give good counter pressure. Ordinarily, if you were to cut a piece of plastic with a knife, it would be like that, and if you used an ultrasonic blade, ultrasonic cutting knife, it would be like this. The tip can attach to any of the phaco machines on the probes, but each machine has a different tip because the length, the thickness and the threads are a bit different in each machine. This was a case done by Dr. Santosh Bulchandani. You can see the pitting in the lens. You have to keep putting viscoelastic after every step to protect and respect the endothelium. Day 1 post-op was 6/6 plano, no cylinder, no stretching of the wound, no SK. 32 diopter lens, 72-year-old lady, opacified IOL, shallow AC. It's a very thick lens in the middle, probably impossible to remove with scissors. This is a very nicely done case by Dr. Samresh from Jaipur. Here he decides to slice the lens into 4 smaller parts. So you can do what you want and use the cutter however you want. How many of us have experienced this? After a perfectly done surgery, a good lens, a good company, and the lens breaks or either shoots through and ruptures the posterior capsule. This is the scariest thing for a surgeon, and you never know when you'll need it. Broken IOLs at the time of insertion, shot through the PC, opacified IOLs. You have to explant a lens because it's dislocated or subluxated. IOL exchange for glare and halos not tolerable by the patient. A post-operative refractive surprise. We'll be seeing more of these after we start doing more and more of LASIK operated patients. So keep it as an emergency, as a standby, like a vitrectomy cutter. ETO it and keep it aside. When you get your tip, please try it on a cheap lens, underwater, in vitro. Grasp it properly with the forceps. Use good counter pressure. This is a patented technology. We've got patents in India, Australia, America and UK, and have applied for some more countries. Now comes the bonus feature. Dr. Pankaj Lande from Amravati has used this tip to chop hard, really hard cataracts. He uses the horizontal chop, goes under the capsule, hooks the cataract at the equator, and uses the IOL cutting tip and makes pieces just like a femto laser does of the cataract into 8 small pieces. And just see how beautifully he has done this. And now piece by piece, using the phaco probe, using the vacuum, makes it easy for himself to remove these pieces. Thank you very much.